in your emergency department who you suspect of having an embolism, whatever it is, be it from history, just general suspicions, whatever it is, you do an ECG, your ECG is suspicious. Now your question is, how am I going to confirm it a little bit more with what I've got available to me? So the other thing I've got available to me is an ultrasound. Right? Now, sounds a bit scary. How am I going to find an ultrasound in the lung? So we're going to kind of logic it out a little bit and try and figure out what would I expect to see. And then we're going to have a look at those things and see what we actually see. All right. Because in essence, an embolism is nothing more than a plumbing problem. Seriously, that's it. It's just a problem of plumbing and what happens because the plumbing is not 100% okay. All right. Okay, so let's start. All right. So like I said, it's to confirm clinical suspicion, right? Because sometimes acute coronary syndrome PE be difficult to differentiate, especially on an ECG. The one we saw on Monday was indicative of an NSTEMI, and I mean had features of an NSTEMI, and history is suggestive of an MI as well. But when you really look at it, it was a pulmonary embolism. So we have to be careful, and it also helps us to look for DVTs, endocardial thrombi, things like that. All right, and then once you can confirm something, you speed up treatment. Because it's easy to knock out an embolus. You just thrombolize a patient, and that's it. Not every MI needs to be thrombolized. Some need PCI, things like that. So that's where it helps. Yeah. All right. So we are going to be spending a bit of time on this diagram. So what we have here is we have the IVC, all right, and the SVC, which feed into the right atrium, the right ventricle. All right. The right ventricle then pumps blood through the pulmonary valve into the lungs. Agreed. And then that blood circulates through the lungs via the pulmonary artery, and then via the pulmonary veins, enters back into the left atrium, which then enters into the left ventricle, and then pumps blood through the rest of the body, where oxygen is used, and then it starts the cycle all over again. Sorry, sure. Okay. Oh, okay, no problem. Okay. Okay, we'll be there just now. No problem. All right, so that's how it should normally function. All right, now let's go and throw an embolus into the mix. Basically a blockage in a pipe. All right, so what do you think is the first thing that's going to happen as soon as a blockage comes into a pipe? Things will start to back up. Agreed. It's like a traffic jam now. So the bigger the blockage, the bigger the traffic jam. The smaller the blockage, the smaller the traffic jam. All right, but let's assume we've got quite a large embolus. Maybe not a saddle embolus there, but let's just say even in one of the main, what you call it, pulmonary arteries, we've got a bit of a backup. What's going to happen to all that blood that's backing up? It's going to start creating pressure in the opposite direction. All right. So which ventricle do you think that's going to affect? Left or right? Backwards now. Right ventricle. Very good. So what do you think is going to happen to that right ventricle? Because remember, this is an acute thing. The body doesn't have time to adjust and compensate and things like that. So what do you think is going to happen to that right ventricle? Get bigger, get smaller? Bigger, very good, right? Very good. So let's put that in there, right? So let's draw it in there. All right. So we expect this right ventricle. Let's just start it from there. We expect it to, oh, let me try that again. Sorry. Also getting used to this thing. So we expect that right ventricle to start enlarging. Agreed. Sorry, I'm not very good with these drawings, but I'll try. Okay. So we expect that right ventricle to start enlarging. All right. So that right ventricle is enlarging, and it can only enlarge up to a certain point. Agreed. Okay. So who remembers Starling's law about contractility in the heart? You don't have to remember it word for word, but just the basics of it. What happens? Give the myocytes stretch, and they will contract harder. All right. So if they don't get stretched, they don't contract so hard. Stretch them, they contract harder, but up to a certain point. Go beyond that, and they can no longer contract, agreed? Because there's no longer myosin and actin bridges, all right, for them to latch onto to be able to pull together, all right? So what happens is initially the heart starts dilating, because this is a whole lot of backup, this whole lot of pressure that's building up. It starts to dilate, so eventually it will reach a point where it can no longer dilate. So what do you think we'll see if we were to look at the heart on ultrasound? We'd see an enlarged right ventricle that's non-contractile. Agreed. So that's one of the things we need to look out for. That's why I say we're going to spend a bit of time on this just to try and logic it out before we get into the actual, ultrasounds themselves, all right? So that's the first thing that we expect to see in the acute phase, all right? Now, what do you think is going to happen to the right atrium after all of this is going on? Because now there's a backup going that way. So what's going to happen to that right atrium? Get bigger, get smaller. Also going to dilate a little bit. So you're going to see that on ultrasound as well. And on the ECG, you're going to see, we saw it on Monday, it's called P pulmonary, very good. So P pulmonary, very high peaked T waves, all right. Now, remember, the way that we're looking at this is sort of top down, okay? We're seeing this top down. So this is anterior part of the chest, and this is more towards the posterior part of the chest. So as that right heart starts to dilate, what do you think is going to happen? It's going to turn the heart around, okay, in a clockwise direction. So in other words, it's going to start doing that. So in other words, the heart that's normally sitting here will now start with the left start moving more towards the front and the right start moving more towards the back as it starts to push the left out of the way, all right? So those are some of the things that we're going to see. And let's go one further back. What do you think is going to start happening to this IVC? It doesn't happen so much to the SVC because of gravity, but what happens to the IVC? And yeah, very good. Yeah, so there's going to be pressure build-up over there. All right. So as the pressure builds up, you're going to start to get an IVC that starts to get larger. Agreed. Its diameter is going to increase. And what we learned the last time was that every time you take a breath, your IVC is meant to collapse or at least go down slightly. But what do you think is going to happen now? Is it going to go down? No, it's not going to go down because basically there's too much pressure built up over there. So you can breathe in as hard as you want. You can't create negative pressure, so you can't suck anything through. So we've already covered quite a bit. So this is, like I say, it's a plumbing problem. That's it. We're just looking at a backup and a backlog. Now leave this for long enough. Eventually you will start getting dilated veins and things like that, but it doesn't really happen that often in pulmonary embolism practice, okay? But in theory, it should happen, right? So you get this large dilated right ventricle that can't contract properly. You get an enlarging right atrium. You get a heart that starts to turn because of the dilation, and you get an IVC that starts to dilate as well. Okay, all right, very good. So now this embolus is sitting over here. Now you may ask what happens to all of these things, and there is something that happens, and there is a way to test for it, and it's called the 60-60 rule, and it's extremely complicated, and I don't want to get into it right now, because it's a whole lecture on its own, how you do venous inflow and outflow in the lungs. So please do not stress about that. Later on in the year, once you guys know how to do cholecystitis, and you guys are experts at echocardiograms, I'll show you guys how to do this, all right? But right now, don't worry about it. So let's just jump a little bit forward. So you've got this atrium and this ventricle that are trying to pump blood through this lung, all right? Now, there's a big backlog. So everybody's been in a traffic jam. It's a whole lot of cars before the traffic jam. And then as soon as you get past the traffic jam, how many cars are there? I mean, do you still have that same amount of cars? No. All of a sudden, there's like 1 car, 2 cars, and they can just carry on, right? Let's say there's an accident on a highway or something like that. You know, as soon as you pass the accident scene, the thing just opens up and everybody can just go flying, but in smaller numbers. Okay, so how much of blood is getting delivered to the left atrium, number one, compared to normal? Much reduced, all right? So it's a much reduced amount. So how much is going to get into the left ventricle? Much less as well. So are these going to get larger or smaller? Smaller. They're actually going to become a little bit, because the actual volume that's inside is less. So we go to Starling's law. So what did we say? If you stretch it, it can contract. Are you stretching it? So how much can it contract? Very little. So how much of blood do you think is getting out over there? Sorry, back on the pointer. Let's close that up, sorry. So we've got this less amount of blood that's getting in there. So how much do you think is getting out? Not much. So what do you expect to happen to your patient's blood pressure? Okay, it will start to decrease, all right. So your patient's blood pressure decreases with the ventricle that's becoming smaller, okay, and unable to push as hard. So how much of blood is reaching the IVC the next time? Even less blood. So even whatever reaches this right ventricle, the amount that it can push through is less. So how much is going to come back to your left atrium the next time? Even less, which is going to get back there. So how much is it going to give the next time? Even less. So it's a nice death spiral that your patient's going into, right? To the point eventually where there's hardly going to be any blood getting into that left ventricle. So the BPs are just going to get lower and lower and lower and lower until the patient demises. So how do we solve this problem? That's the question. Even before we jump onto the ultrasounds, what do you think will solve this entire problem? Yes, removing the blockage. Very good. So if you remove the blockage, everything's sorted out. Okay. So that's when it gets into the management phase of it. But the problem is that if you never get to the diagnosis, you can't do the management as well. So how do you manage this? Thrombolysis, thrombectomies. There's lots of ways to do it. And thrombolysis is the most common available to us. All right. Now, the question often, we'll get to the proper management later on, but I just want to say there's a lot of dispute as to how exactly you should do it in the lung and what's the best. But in our situation where we stand, as normally in regional hospitals, district hospitals, some of our people on Zoom, you only have thrombolytic agents available, and that too, not all of them. Sometimes you've only got heparin available. Sometimes you've only got alteplase, or you've got, what's the other one? Just on the tip of my tongue. Sorry, it's all the hard drugs now, my brain. But you know, there's those few, all right? Some of them are not even indicated for pulmonary embolism and things like that. But sometimes that's all that you've got, you know? Now, the thing is, when I say it's a plumbing problem, I really mean that. The smaller the embolus, the smaller the backup, the less acute, all right? And the more your patient can maintain what's going on, all right? The higher or the bigger the embolus, the bigger the plumbing problem and the worse it gets. There's one other thing that I just wanted to get to you guys as well. So in the lung itself, how much of blood is actually, let's say it's here, all right? The embolus is there. You can see it's blocked off this entire section of the left lung, all right? How much of, let's say, deoxygenated blood is reaching that amount of the lung? Much less, agreed. So how much of oxygen diffusion can take place? Much less, all right? So how much of oxygenated blood is reaching the rest of the body? Much less, all right? So you expect your saturation to drop as well. But this is something, have you guys heard of VQ mismatch? All right? This is a very typical example of a VQ mismatch, which means perfusion. What's it? Sorry, ventilation perfusion mismatch, all right? Sorry. So that's a simple way of saying that the amount of blood that's reaching there is either not sufficient, or the amount of blood that's reaching is sufficient, but the amount of oxygen coming across is not sufficient. So that's called a VQ mismatch. Although in majority, 99% of the time, they're actually talking about the amount of blood that's reaching the lung, right? So that's what we call a VQ mismatch. And it's very misleading because V and Q have nothing to do with perfusion and oxygenation. I mean, why don't they call it PO mismatch, you know? So it's, but you get what I'm trying to say, all right? So we know what we're expecting to see, right? Let's just recap. So we are expecting to see a patient who is, on ultrasound now we're talking about, who's going to have an enlarged right ventricle and enlarged right atrium. We're expecting to see a right ventricle that's not functioning as well as it should, maybe not completely acontractile or maybe hypodynamic. We're expecting to see an IVC that's increased. We're expecting to see a left atrium and left ventricle that are almost collapsing on themselves maybe, or not pushing out as hard. And clinically, we are expecting to see a patient with low SATs, low BP. And what's the other way that the heart can overcome low BPs? Increase rate. So you can have a tachycardia, but not all the time, right? Again, it depends on where it's happening. Okay. All right, so I hope that makes a bit of sense. Okay. Now, it's easier to logic it out because now when we go, it will make sense on the pictures. Okay. So let's have a look and see if this thing will go forward. Right. So tell me, first of all, what view are we looking at over here? Are we looking at the subxiphoid view or the parasternal long axis? Which do you think? Very good. So this is the parasternal long axis. All right. So we put our our probe just next to the sternum. We've pointed our indicator towards the left elbow. All right. So what we are seeing here is we are seeing the apex of the lung. Right. We are seeing the right ventricle. We are seeing the left ventricle. We are seeing the left atrium, and there we are seeing the aorta as well. Right. So that's what we expect to see, and this is the descending aorta over here. All right. Can you guys see it over there? Okay. It's a bit dull, eh? I think it's just because of the, well, you're welcome to watch it on this. I can just turn it a little bit, right? All right, is that a bit better? Right. I think it's because it's the amount of ambient light. Right. So what do we say we expect to see in the right ventricle? So that's our right ventricle. What are we expecting? Very good. So what should be larger, the left ventricle or the right ventricle? In a normal line. All right, but in this case, which one is larger? Right ventricle by quite some way, isn't it? The left ventricle should be, this should be about, if you divide this into thirds, this whole region, 2/3 should be taken up by the left ventricle, 1/3 should be taken up by the right ventricle. Now we've got almost opposite that's true, all right? Okay, so we've got almost opposite that's true. We've got this very dilated right ventricle, okay, because of that amount of backup that's happening. Okay. And what do you notice about the walls of the right ventricle? What did you say is going to happen? Just this wall that you can see there at the top. Is it moving normally? What's happening? They're just kind of sitting over there, right? Except for which part? The apex. Agreed. And the reason for that, you can't actually stretch your apex that much. If you stretch your apex too much, the heart's going to take. So it doesn't actually stretch out. So the apex still retains some contractility. All right. So this particular one that we are looking at now is called McConnell sign, McConnell sign, which is essentially the winking sign. Because what's happening is the thing's kind of doing that. All right. It's not really winking, but you know, in the old days, I don't know, people used to describe it, right? But kind of the corner is winking. Right? And this is almost pathognomic of pulmonary embolism. Even if you don't know the other things, it's pathognomic. Because what's happening is the rest of the thing is dilated to the point that it can't contract anymore. And now you have this apex that's kind of moving a little bit. Right. Okay. Now, the other thing we can look at is the septum. So what's happening to the septum? Can you notice? Which way is it moving? Towards the right ventricle or the left ventricle? Is that normal? No. Which way should the septum move? It should move towards the right. Agreed, because your left is supposed to have much higher contractility. So the reason why we're seeing that is, again, because this right ventricle is so dilated that it's actually pushing it in the opposite direction. Okay, so that's one of the things that we see. We come again to our left ventricle, and what do you notice? Even our left atrium, left ventricle, what do you notice? Small, tiny, hardly visualized actually in certain points, right? And it's trying to keep up, so it's going quite fast. We can't really keep up with everything. Okay, makes sense? Okay, so as soon as you get rid of the blockage, everything will go back to normal, right? So let's just get on to the next one. Let's see from there. All right. So this is something I haven't taught you guys yet, which is the parasternal short axis. Right? So the parasternal short axis, instead of looking at the heart from this direction, we're now cutting it in that direction, which we'll get to. But I just wanted to illustrate the difference. Right? So in the parasternal short, this is the right ventricle, and this is the left ventricle. And it's just to show you the same thing from a different point of view. The left ventricle we can always notice because of its muscularity. Right? But you see the same thing. You see this highly dilated right ventricle, extremely dilated actually, with a wall that's not moving. All right. Now in this one you can't see the apex because the apex is kind of further down. You kind of move the probe until you get to the apex. Right. Here we kind of mid ventricle. And again, you notice the septum falling the wrong way. All right. And you notice the ventricle is very small, hyperdynamic, trying to keep up, but unable. Okay. But it makes sense from what we discussed earlier. What we expect. Okay. So these are the things that you need to know when you are having a look at it. Now, this is also one that I haven't told you guys. This is called the apical view, all right, or the 5 chambers view. It's basically you get your patient to lie down and you have a look through the apex, all right, which you do. Don't worry, I'm sure you guys will. That it was just to illustrate this point. Right. So what happens here again is that we've got right ventricle, right atrium, left ventricle. still abnormal. Okay. We see that this wall is hardly moving, right? And we see an apex moving over there, right? That's O'Connell's sign. Again, we see this enlarged right atrium. We see this left ventricle and left atrium and left ventricle that are trying. You know, they're pushing, but they're not winning. And we see the septum that's kind of dancing, almost undulating like a snake over there, which is all that we expect to see, right? So just to show you, if you can't see it from one point of view, maybe you can see it from another point of view. But don't stress about these views for now. I am going to show them to you at a later stage, right? Because there's a whole lot of mentalities that come with using those views as well. Okay. All right. And now we come to the IVC. And what did we expect to see on the IVC? Said it's going to be big or small? Big. Collapsing or not collapsing? Not collapsing at all. Great. And in fact, in this one, this is actually the bottom of the right ventricle that we can always see. We have the right atrium and right ventricle. And we can see even those are hardly moving. Right? So this is just another thing we can use to confirm our diagnosis. Right? So once we get to this point, what it means is that we've actually gone quite far. You've more or less convinced everybody that you've got a patient with pulmonary embolism. Okay. And like I said, that's not the be-all and end-all of it. Let's just go back to that. Right. So that was just the last one. So the question is now, you've got this patient with this pulmonary embolus that's sitting over there. They're busy dying, right? Physician's at home having supper, all right? Doesn't want to come out because they're insisting they want a CT angio before they'll even think about leaving their home, which is what happens. Right? Even if you present to them all of these signs, they're like, but you're an MO in casualty, you don't know all these things. Even though you're telling me them, but you don't know them. I know you don't know them. You know, that's the attitude, right? So you are now stuck with this patient. Alternatively, you are working in Bleikkiesfontein, where there's no MOs in internal medicine. In fact, there's nowhere to transfer the patient. Okay, how are you going to treat this patient? What are you going to give? Let's say it's quite serious. BPs are dropping into the ground. This patient's sats are in the ground. You've got all these signs, even if you didn't do an ultrasound, but even from the ECG, the history, it's a lady 3 weeks after giving birth, she's got signs of DVTs on both legs, collapsed. The ECG is almost typical. How are you going to treat her? That's the question, because you don't have access to fancy drugs, maybe, which if you do is great. I mean, to give thrombolysis is very easy. You just put up a vein, you look at the leaflet, it tells you how many milligrams per kilo to give, you give it, and that's the end of it. You sit back and you watch. But the question is, what if you don't have that? What else do you have access to in every emergency department? Heparin, very good. But what's the problem with heparin? Heparin's a tank. It just attacks everything. Agreed? Am I right? It's like going to kill a mosquito with an AK-47, basically. Because once you give heparin, there's no coming back from that. You know. So number one, you have to be 100% sure, all right? But if it's indicated, and it has to be given, all right? Now the question is often how much. I'm going to tell you, but you will forget it, all right? Which means that just so long as you know it has to be given, you will remember to go and Google it. Because luckily these days, I haven't seen any one of you with a dumb phone. All of you have a smartphone with internet connection, so you can Google it. So you Google heparin dosage in pulmonary embolism, all right? And the normal dosage is 7,000 international units. It depends. It can change sometimes based on weight as well, all right? So if you've got a very large patient, you may have to give more, but 7,000 is more or less the average, all right? And then you've got a follow-up dosage that takes place, I think, about 2 hours later. It's also about 1,500 units or 2,500 units, all right? So what happens is heparin gets in there, and heparin basically breaks down all clots. It doesn't discriminate. It doesn't say the patient has a pulmonary embolus, so I'm going to go in and just get that pulmonary embolus. So when can't you give heparin? Very good. Anything else? Very good. When else? Recent surgery. So what you're going to do with your pregnant lady who just had a seizure? You get what I'm saying? All right. So you don't just rush to give the heparin as well. Patients with facial trauma, patients who've had CVAs, hemorrhagic. There's a whole list of contraindications and relative contraindications to thrombolysis. So before you as Dr. So-and-so decide, I'm going to give heparin, to protect yourself from a medical legal point of view, again, you Google contraindication list for thrombolysis, and you check it off. In our case, we've got it in our emergency departments on those clinical forms. And you say, right, okay, patient doesn't have this, doesn't have this, doesn't have this, doesn't have this. There are no contraindications to thrombolysis. Patient is presenting with such and such a severe disease. I'm going to give heparin. Then if something goes wrong, you are covered. Now, if your patient is relatively stable, presented with a bit of chest pain, maintaining oxygen on SATs, BP is within the normal to lowish normal range, and you go and give heparin in that case, nobody's going to come to defend you. This you're talking about patients who are dying. They're going to die in the next 10 to 15 minutes if you don't do something. That's the only time that you use it. And I've never had to use it here, luckily. All right. So hopefully none of you are placed in that situation, but it could happen. Just know that you have heparin as a tool that you can use, okay? But I wouldn't advise just whooping out the heparin every time you diagnose a pulmonary embolism, all right? Better to get, if you're at a district hospital, you get the regional hospital involved, all right? Transfer the patient as quickly as possible. Or alternatively, if you are like in our situation, you get the regional department involved as quickly as possible. Now, if the patient is not doing well, so physicians are refusing to come, not answering their phones, you follow the same procedure. You go through your thrombolytic checklist, or you phone Dr. Mohammed and you say, listen, this is a patient that I've got. I come here in 12.5 minutes, which is my record, and then I go through it with you and we give it together. So the responsibility falls on me, okay? But that's basically how we treat them, okay? So once you get rid of the clot, blood starts flowing, right ventricle decreases in size, it can now start contracting. More blood is going to the left ventricle, it can start contracting, your BP start going up, your perfusion, your VQ mismatch is gone, the patient starts oxygenating properly, and then your patient has to be monitored in an ICU setting. Okay. After this, the only other thing that you would do is that you would look for sources of emboli. All right. Now, there's cardiac sources, which we haven't looked at yet. We'll look at later, but DVTs we've done. All right. So you guys know how to look for a DVT. That's where you would go next. Say, does this patient have signs of a DVT? If this patient has signs of a DVT, that's where my embolus came from. You get what I'm saying? All right. Any questions? Yeah.
Let's say you have a functional patient who is not making the call and they have a risk of from immobilization.
Yeah, exactly.
And then they present with this acute chest pain and all the signs, and it might be like, how do you differentiate between?
Okay. Now, what will happen is, as compared to, well, actually, there's two ways to differentiate it. Number one, a lot of the signs that are happening here are in the acute stage. All right. And what happens is with COPD and COAD patients, whatever you want to call it, they have a more chronic course. So what happens is that, let me get it back to this, sorry, 1 second. Let me get it back to this one. So in the acute phase, you'll notice, number one, this wall is not hypertrophied. It's just stretched. So what you would expect with a patient with COPD is that over time, the right ventricle would have adjusted to it. So you start getting more of a hypertrophied ventricle. Number two, you don't get just this apex that's functioning because it's not an acute thing. It's not an acute stretch. So you get this patient with an entirely functional right ventricle that's able to keep on pushing through, all right? However, you do still get a collapsing left ventricle. You do still get a collapsing left atrium. And that's one of the harder things to differentiate because if you're not sure how to look at the two, all right? Now, when you get that, you have this big hypertrophied right ventricle and very collapsed left ventricle. That's a sign of pulmonary arterial hypertension, all right? Which Viagra was created to treat, by the way, right? That was the whole point of creating Viagra, was to actually treat that problem, okay? So what you do in those cases is that you actually need to treat the, what you call pulmonary arterial hypertension, which we don't have the capacity to do. Most of these patients have accommodated over time. So even though they present in the acute stage, sometimes with acute exacerbations of COAD, they don't necessarily present with the same problems as a pulmonary embolus. They are more prone to ischemias. They are more prone to ischemia because, number one, they are not getting sufficient diastolic, what you call backflow into the coronary arteries. Number two, just pure hypoxic ischemia as well, if they're having an acute COAD attack. But the difference would be here in the right ventricle. Right ventricle becomes hypertrophied to the point where it actually looks similar to the left ventricle at some point. Okay, and you can see that the entire thing is working. So it's not an acute thing, if you get what I'm saying, all right? So I hope that answers the question. Okay, so as compared to a pulmonary embolus, which is an acute blockage, normally in one little section. This COAD tends to be a more of a diffuse blockage. All right, so it's kind of like having multiple microemboli over a long period of time. So the right ventricle gets a chance to adjust and go through. But eventually, as the PAH increases and increases, eventually the left ventricle and the left atrium also collapse. The second thing is the ECG findings are completely different. All right, so COPD patients tend to have something called multifocal atrial tachycardia, which looks completely different to what we saw in our ECG. Now, on Monday, what we realized was that there's a lot of signs of pulmonary embolism on ECG. But the most common one is to have inversions of the T wave simultaneously in the inferior leads, 2, 3 AVF, and in the anteroseptal leads. That means V1 to V4. So you have all these T wave inversions. In COAD, you don't have that. You have signs of ischemia if there's an ischemic component. But the most common thing you see is this multifocal atrial tachycardia. So that means when you look at your rhythm strip, you are looking at your P waves. So you have a patient who's tachycardic with P waves that look completely different, at least 3 different types. Okay, and that's how we diagnose that. All right. So those are the 2 ways that you can differentiate the 2. Okay. Secondly is also history. COAD patients don't become COPD. They were fine yesterday. Today they're not. So you have this history. And it doesn't mean COADs can't have pulmonary embolism, like you say. But when they do have pulmonary embolism with this, the ECG also changes. Because now you have this hypertrophied heart that's now going through an acute change as well. So when they have an acute change, you have this hypertrophied but stretched, but it's still unable to contract. So you tend to get O'Connell's sign as well. And you also get a quick deterioration. So BP start to drop very quickly. Saturation start to drop very quickly. There's not much wheezing in the lung or, at silent areas and things like that. But it can be difficult. There's no doubt. I'm not saying it's easy. And you'll tend to find the ECG changes that are pointing more toward the pulmonary embolism. The good part is that because these patients have compensated over all that time, even though they have an acute stretch, but because they've got this hypertrophied ventricle, they can sort of push a little bit more. So they tend to manage it a little bit better. But they're already at the end. I must be honest. If they are so bad, I mean, are you going to do anything? Are you going to save them? That's the question. Because for a patient with COAD to be completely bedridden, you must know how far that COAD has gone. Because most of them are functional. They can move around, even if they've got their oxygen tanks and wheelchairs. So in order for somebody to be completely immobile, not easy, that's for sure. But it's a good question. Appreciate it. Any other questions from anybody on Zoom as well? You can just raise the hand. It's an interesting topic. It's a difficult topic. It presents to us sometimes some of the more difficult diagnostic challenges, pulmonary embolism. And we've had lots of patients where it's been missed. For whatever reason, poor history taking, poor investigation, relying on D-dimers for some reason. D-dimers don't always have to be super high for you to diagnose a pulmonary embolism, but it helps, And D-dimers can go up in a lot of situations, sepsis, pregnancy, other coagulopathies. There's lots of things that can cause it, I mean, if that patient has a big scab on the hand, they could have high D-dimers. Doesn't mean that they've got a pulmonary embolism. So, it's not good to rely on that. You've got to rely on other things as well. Okay. So I hope everybody got it. I hope it makes sense. All right. Like I say, any other questions? Anything you're worried about? Okay. One of the other things I always get asked is now my patient needs to go to ICU and get thrombolized. Which side should I put the CVP in? Don't put a CVP. All right. When your patient needs thrombolysis, don't put a CVP. I've seen doctors actually want to do that because now remember your patient's going to bleed out from their CVP. It's my patient's going to ICU, so I must put a CVP in. No. In these cases, they just need a peripheral line. That's it. Okay. Even if you're giving heparin, you're going to give it through a pulmonary. If for any reason you have put a CVP prior to that, then you're not in a lot of trouble, but that's why I prefer actually the femoral CVPs because at least you can compress them. Whereas with your jugular and your subclavian, you can't. Yeah. But don't rush to put in CVPs in patients. That's the thing. All right. Okay. If there's no other questions, I can say nobody on Zoom is asking any questions as well. Then we'll end there for today. And we won't have it. This Friday is holiday. We're not going to have so we'll have one next week, Wednesday. Okay. All right. Let's just end it there. Bye-bye.